So today we're going to talk about AK, talk about some of the management. So we've heard a lot about more about AK now. We have the recent guidelines that were published by the AED, and I was involved in that. So it's helped increase and improve our paradigm. So, AK can be field pattern, it can be individual. So the presentation is variable, but the prevalence is increasing in our population. So as you can see, this is probably still the most common thing dermatologists do. AKs, treating AKs and biopsies are probably still the two most common things that we do all day long. The pathogenesis of AKs, what's really important to remember about the pathogenesis of AK is multiple mutations that are leading from AK to squamous cell carcinoma and highly connected to our immune system. So our immune system is watching these, or surveillance, and that's what helps either prevent or drive AK to go towards skin cancer squamous cell carcinoma, which was our main concern. As you can see, histologically, a lot of inflammation is present in AK. They can sometimes be difficult to distinguish between AK and squamous cell carcinoma, but the inflammation is what's really always present, and that's our immune system that's watching these and hopefully trying to prevent them from progressing. As Dr. Ferris, mentioned about dermoscopy, when you look at dermoscopy, it can maybe help you differentiate between AK and squamous cell carcinoma. As you can see, the strawberry pattern located here on the left in the facial non-pigmented AK with this vascular pattern that kind of looks similar to that strawberry pattern. And then on the right-hand side, a squamous cell carcinoma with a very similar pattern, but more of a swirling pattern as opposed to the center pattern that you'll see in AK. These are the classifications that we use for our study. So the Olsen scale is the most common one that is used in most of the studies that we're doing now. In fact, the most recent registration studies use this scale. Of course, there's a lot of variability, inter-rater variability for the Olsen scale, so it's still hard to accurately classify an AK based on its thickness, but we know that the ones that are thickest have a highest risk of squamous cell carcinoma progression. There's other classifications out there as well for AK field assessment, and so we're learning more about how to use these in real-world clinical practice. So what are the things that are being done now? Cryosurgery, it's still a gold standard for us to use in our clinic, but how really do we understand how well this treatment works and how much do we really do it? Do we really treat 5 seconds or more? Do we really treat greater than 20 seconds to get an AK to clear? If we're trying to achieve clearance rates with cryosurgery, we're most likely going to be causing hypopigmentation and side effects. So if we look at that more scientifically, ALA PDT, commonly accepted now in our practice. We're using it quite a bit. We have 2 molecules that are approved, the 10% and the 20%, used with different light sources. Most of us are still using the blue light to treat with both, but when you put the red light on it, you may get more efficacy. And there's new lights being developed now that are much larger and get much more power, and it's much more painful for the patients to get the treatment. So we have to figure out how to get better efficacy without causing a lot of pain for our patients. We'll see emerging studies coming out. We're using AK, using photodynamic therapy on the extremities, so we'll see more of that coming out in the future as well, but there's some of combining that with adapalene or other retinoids can help improve our efficacy and our outcome when treating, especially on those areas that are off face and off scalp. MAL PDT never made it to the United States. There was a study that was started with daylight PDT. It can have excellent efficacy, and it's very widely accepted in Europe, but it never made it here. Galderma did a study. It didn't meet the endpoint they wanted for daylight PDT, likely due to study design. Everyone got curettage in that study, so we probably weren't able to tell the difference between the placebo and the active group for the daylight PDT. So hopefully we'll see that come back, and we'll be able to actually get an approval for daylight PDT in the United States. It will be really nice to see. You can see combining calcipotrials, and another thing you can do, vitamin D with MAL PDT and or ALA PDT may help improve outcomes to some extent without increasing the risk of safety problems. 5-fluorouracils are a gold standard medication in the guideline. It received high marks. It received a strong recommendation for use just because it works well. It's just the efficacy. The efficacy is good, but the adherence can be an issue. Of course, a lot of patients, this is the treatment that they love to hate. They don't like to they don't like to go back on this treatment once they've had it the first time, but it certainly works well. Chemo wraps are still very effective. We're still using those for our patients. And with these lower extremity lesions now, thinking about whether immunotherapy will actually have a benefit. In my next talk, when we talk about the PD-1 inhibitors, I'll just mention a little bit about what these can possibly do for AK, especially when patients have this field cancerization here. If we can stop that immune system or get that immune system to kind of wake up and get some of these AKs treated, we may see some efficacy with that. So it may be something to think about in the future. Imiquimod, of course, is still one of our friends. Anti-tumoral effects, it works primarily on the innate immune pathways, so there's also some new developments coming out with new biosimilar molecules and other molecules that follow the same pathway as imiquimod. We have good efficacy. It has a good recommendation in the guideline, so it's still being used regularly with relatively decent adverse events. Diclofenac, non-steroidal anti-inhibitor, COX-1 and COX-2 inhibitor, so another molecule. Problem with this medication, low efficacy and long treatment times reduce the adherence of our patients with it. Ingenol mebutate, unfortunately, is not here anymore. It was removed from the United States and from Europe due to what they thought might be an increased risk of squamous cell carcinoma in the unpublished European data that was put out. So while we were doing the guideline, they pulled it from the market in the EMA, the European Medicines Agency, and then subsequently the Leo, the company that was keeping it here, decided not to continue marketing it, so we unfortunately don't have that anymore, although we saw some good results with that. So just going forward into some of the studies, so looking at some of the randomized double-blind controlled studies that were looked at. This is a New England Journal of Medicine article with the 4 treatments that we're used to seeing. It's probably one of the largest studies that we have comparing the most common treatments except for tirbanibulin out there, continuous areas on the head and neck. And here's the outcomes as we expected. 5-fluorouracil works well, imiquimod works well, PDT works well, and ingenol mebutate still works well. It's just that, we don't have that one anymore. So, these all relatively do quite well. I think still 5-fluorouracil and imiquimod are our gold standards. And then compare that right there to the guidelines. So this is 2021 and then 2022 with the US guidelines that were just published. And so cryosurgery, everybody asks, why was that given a good clinical practice statement? There really isn't a whole lot of randomized double-blinded controlled studies in the field of AK in a general sense. Really, the most recent one that we got was the tirbanibulin study, the phase 3 double-blinded studies that were done. Those are probably the most rigorous studies that we've seen in a while for AK that led to the approval of that. So that one got the focus update with a strong recommendation, primarily because of strength of evidence. As you know, the guidelines is a systematic review, and so you have to start out at the beginning of a guideline and decide how you're going to look at the data, what time frame, and what studies are going to be included from the beginning. So combination therapy, just some different things, none of this is hard and fast data, but just combining cryosurgery with imiquimod, and we all do this every day in our practice. We're all looking for ways to combine treatments for AK, combined modalities. So I just thought I'd run through a couple clinical scenarios, just looking through. So our patients with single AKs, we're still using cryosurgery, of course. It's recommended to do that for, when you have single mild to moderate AK. And then going into multiple AKs, in our practice, we're adding in PDT, we're adding in 5-FU, tirbanibulin, imiquimod, calcipotriene. We use a lot of compounded calcipotriene the calcipotriene with 5-FU, we're using a lot of that combination. It helps improve the adverse event profile. It costs about the same as the 4% Tolac, that's out there, the 4% 5-FU. So we've got, different things to use there. As far as patients with history of skin cancer, it increases our surveillance, so we're seeing them more often. We're increasing the potency of the 5-FU, so we're starting to raise our hackles a little bit with what we're going to do. ALA PDT, of course, is a standby in the practice as well because it's available and it's covered. I think that's one of the biggest things now with the new medication, tirbanibulin, is coverage is still a bit weak on it, so hopefully that's going to improve over time. It'll help us get, more use of it. And these are the patients we start to get worried about when they have recurrent AKs. We're really worried about skin cancer. We've got to follow them carefully to make sure that they don't progress, and then hit them a little bit harder with that 5-FU. And of course, our special populations, the guideline did cover to some extent immunocompromised patients, but there was insufficient data to really say much about how to deal with them, so we just end up being more aggressive in our surveillance and our management of these patients. So tirbanibulin hit the market last year before, and this is a microtubule inhibitor. It's a reversible microtubule inhibitor. It inhibits the polymerization of the growing microtubule during the mitosis phase. It's very similar in mechanism to the way colchicine works. Colchicine is more of a permanent inhibitor. This is more reversible. Thus, the adverse event profile is better for AK. It causes apoptotic cell death as opposed to necrotic cell death, which is what we see with 5-FU. So it's a very different mechanism causing a different outcome. And so you end up with a little bit less on the adverse event profile while still maintaining efficacy. The head-to-head studies were published, about a 49% pooled complete clearance at day 57. So, you can tell your patients in a couple of months, half of you are likely to be clear, another 75% will be partially clear, defined as the 75% or greater clearance in the treatment area versus vehicle. So that was a good outcome for us in dermatology because we got a nice head-to-head study. We don't get to see them very often, and so it's nice to get those out there. Taking that data, and then we started a real-world study with 300 patients in 10 sites. And this is just some of the data that was published recently at the winter meetings, and it's just taking a look more in detail about how the clinicians felt the topical was working with tirbanibulin, and then how likely they were to use it again. And luckily, in the real world, it works a little bit even better than advertised. The patients who were administered are likely or completely or partially cleared in 75% approximately, and then the majority of the doctors and the PAs that were in the study would use the topical again. And then taking that to PRO, so we did a whole lot. There's going to be a lot more data coming from this study, but just looking at the Skindex 16, which is a common PRO. We're used to this one. It's validated. This is the one, so starting to show some improvement in the signs and symptoms and the emotional impact of what happens to our patients when we treat their AKs. Certainly, they're bothered by it. Certainly, it has an impact on their life. It may not be coming to the forefront in the discussions in our clinic, but when you actually ask the questions of them, and when they're on their own at home, doing the app at home, just answering the real world questions, they tend to, kind of show us what's going on in their life. I already mentioned the calcipotriol combination. A calcipotriol can also be sort of an anti-tumoral agent. It's approved for psoriasis. We're mixing it in compound quite a bit. It didn't achieve any kind of significance for us to include it in the guideline with any real recommendation except insufficient evidence. But unfortunately, there's not a lot of incentive for companies to go and study this, but the efficacy is good, so a lot of folks are using that. This is some of the new things that are coming out. There's not a lot of real good data on emerging treatments in AK. This is VDA1102 that's in phase 2. It works kind of at the mitochondrial level to cause tumor cell death. Data okay so far, so just to be aware, you'll see this if you're looking around on FDA.gov. Resomicromab is another medication in phase 2 with decent clearance. The whole point is to help reduce adverse events. The mechanism is increasing IL-6, tumor necrosis factor alpha, interferon gamma. So it might see the resomicromab come around. And then KOH, potassium hydroxide, interesting enough, it's pretty cheap way to treat AKs. It doesn't work that bad, after a month versus 5-FU. It's actually not too bad. And after 3 months, you can see the data is not bad. It's also a lot less expensive if it can be, produced in that way with adverse event profile kind of similar to what we're used to, so not too bad. So we may see more of that coming out. And then, in our practice, we do like to combine ablative CO2 resurfacing quite a bit with different things we do. More of it is a drug delivery mechanism. It hasn't quite achieved the data we're looking for yet, but more studies would be helpful on it to increase. We use it with combination with PDD to a light passive carbon dioxide laser to help improve the ALA penetration with the skin. Of course, cost and availability of the device is always a factor when we're using the CO2 laser, but we do like to sort of add that in the cosmetic side of the practice. This is a study that we just did recently and just published, just looking at some of the cost and efficacy and clearance. Just gives you an idea. If you can take a picture of this and go take a look at it, just gives you an idea across the board, across this therapeutic area, what's going on with the different medications. You can see the complete clearance rates overall, including tirbanibulin there at the bottom. And then looking at, some of the adherence, so how well patients are likely to stay on the therapies. You can see diclofenac has a little bit less adherence. It's kind of data that we're used to seeing, but really formulating that into a published document. So, these are some of the things that we're thinking about now with AK. So, what are we looking for? We want better efficacy. We want larger field treatment, with our topicals to be able to treat arms and legs. We want to look at what's new, what's coming out. New combinations, special populations, of course, I mentioned immunotherapy. That's something I think we hopefully will see more of. And right now, of course, we only have approvals, and we'll talk about that for squamous and basal in dermatology. But I think it's when you treat patients with when you give them IV cemiplimab and you see their AKs light up, and then you see how they clear up, it's really, really quite interesting. They're almost the skin cancer, but they're not. So those are some of the gaps in care. Just a couple of emerging treatments that you may see out there, these SRT-100 gel, DFT-07 cream, that's kind of an NSAID, and then upregulation. This is all tumor necrosis factor signaling pathways and innate immunity that these new molecules are working on. And this is just sort of a little bit of a how are we going to look at these trials in the future? What should we be looking at? The core outcome set is sort of in the small circle. What we really need to look at, long-term follow-up, progression to SCC is the next phase of what we need to see, and of course, quality of life measures will become important. And so it's a greater and greater problem as far as money goes for us, and spending money on AK over time. And you can see the costs here. You can see highlighting the, most people, will know that diclofenac still has a high cost. Tirbanibulin has been criticized a little bit just because of the cost, but then people are seeing this better efficacy and adherence to that medication due to its short treatment. 5-FU, a gold standard, reasonable, imiquimod. So just some data on cost. And so AK is on the rise. We're continuing to do a lot of research on it. Of course, I'm glad to see it starting to come into fruition, into light in dermatology, and hopefully we'll see more in the future. So thank you very much for that.